morning, afternoon, and evening to everyone. I would like to first thank Healthcare Insights 2025 for this opportunity to present my area of interest. As mentioned, I am Olivia, and I'm honored to speak to this distinguished audience of healthcare professionals and educators. So today I'll be presenting on a pressing challenge in medical education, which basically has been an issue for a while, which is enhancing prescribing competence to improve patient safety. I will be covering 4 main areas surrounding this topic, and these are drawn upon recent research, global frameworks, practical case studies, to propose a meaningful reform in the medical education arena. So let's begin by understanding the scale and implications of prescribing errors worldwide. Prescribing errors are among the most common preventable causes of medication-related harm. Studies have revealed that error rates of up to 15% has taken place with handwritten prescriptions, and up to 8% even with electronic systems. These are quite common in healthcare settings, occurring in about 7% of total medication orders, and up to about half of hospitalized patients sometimes can experience some sort of prescribing errors. The most common types of prescribing errors are dosage-related errors and also antimicrobial use errors in that area. In one particular study, it was found that nearly all medical students make at least one error during an assessment. These findings point to systemic issues in education and training. While e-prescribing, i.e. electronic prescribing, can help reduce certain errors, it does not totally address foundational gaps in clinical judgment or pharmacological understanding. So our objective is to mainly explore how educational reforms can address this patient safety issue in line with the theme of our conference today. So in the rest of the presentation, I'll also be sharing the implications for medical education and practice to address this issue. So I'll be talking more on the need for comprehensive training, the sorts of training that are recommended, the areas for improvement, as well as ongoing challenges. So prescribing errors aren't just clerical mistakes. They are clinical events with serious consequences. They can contribute significantly to adverse drug events, hospital complications, extended hospital stays, and even morbidity and mortality. Economically, they also place an enormous strain on healthcare systems. It's crucial that medical education takes this into account, as prescribing competence must be viewed not just as an elective skill, but as a core component of patient safety. It's time that we embed this understanding into our curricula, our assessments, and professional development programs. Very often, junior doctors are a high-risk group due to a lack of confidence and preparedness. So highlighting the need for improved education and systemic interventions. So to mitigate these risks, our education systems must evolve. So this will involve medical schools. We must ensure medical graduates are not only knowledgeable, but confident and competent prescribers. This involves strengthening instructions in a few areas like clinical pharmacology, integrating case-based learning and experiential learning, and also embedding prescribing safety principles throughout the training horizontally and vertically. Many of the institutions must create environments where students practice and reflect on real-world prescribing decisions, including learning from mistakes, from a safe and supportive space. So this can include, as I've mentioned, e-learning modules can be used for students to learn on safe prescribing. Case-based learning scenarios can be used. Interprofessional education sessions, which I'll elaborate further shortly, and also experiential learning opportunities. So moving on from the prevalence and impact of prescribing errors to what is the current state of prescribing education globally at the moment. Looking from a wider perspective, we found that structured training programs are essential to reduce the variability and to also ensure every graduate attains a consistent standard of prescribing competence. Informal or opportunistic learning is really insufficient. We need to define learning objectives, having hands-on practice, giving regular feedback, and also have robust assessments. Otherwise, without this structure, we risk perpetuating a cycle where junior doctors feel ill-prepared and patients bear the consequences. It was found that there is a wide global variability in how prescribing is taught. These disparities translate into inconsistent graduate competence, and we must work toward a more, perhaps, ideally global minimum standard for prescribing education, one that ensures every medical student, regardless of institution, has the foundational training needed to prescribe safely. Implementing an evidence-based framework like UPAC, which is something that I will go into more detail shortly, again, has been a success recently, which standardizes the training and improve prescribing outcomes. It was found that institutions that have adopted UPAC, which is a prescribing framework, reported reductions in prescribing errors and greater preparedness among graduates. Going back a little bit, prior to 2010, studies have shown that there is a concerning decline in clinical pharmacology teaching. Taking UK as an example, it was found that only 60% of medical schools have dedicated courses, and about 72% are actually integrating it vertically in their medical curricula. This leads to graduates entering the workforce with knowledge gaps, low confidence, and high risk for errors. So prescribing is a complex skill. It requires more than just memorizing or rote learning. It demands contextual thinking, patient-centered decision-making, and also continuous feedback, none of which can occur without a dedicated instructional time within the curricula. Let's examine two major systemic issues. First, the lack of standardized curriculum, as I mentioned, and two is there is insufficient hands-on practice. Without a consistent framework, prescribing education is left to individual discretion, which is happening in many medical schools and in many countries, leading to variability in graduate competence. There are also too few students engaged with prescribing in clinical setting or simulation. Practical experience, including electronic system training, must become a core and integrated part of medical education, not just a supplemental or optional component, which may be the case in many schools currently. A survey of UK medical schools revealed that there is significant diversity in the clinical pharmacology and therapeutics teaching approaches. There is a variability in teaching responsibilities as well. It was found that 70% of schools, they utilize pharmacologists for their teaching, 2/3 of which are clinical, and a third of them are non-clinical staff. About 20% of schools, they utilize non-specialist clinicians to teach this. And about 7% of schools, they utilize pharmacists to deliver this part of the teaching. Some of them utilizes lectures, the majority actually about 90%. 50% will incorporate some form of e-learning, and about 63% have implemented a student formulary. So moving from just the UK to more global view, surveys have also shown that students feel underprepared in other countries in the world, and this is a concern that extends globally. Junior doctors are often the most frequent prescribers and also the most error-prone due to the lack of experience. So this paradox, assigning high responsibility to the least prepared, is a recipe for preventable harm. Effective prescribing will require not only pharmacological knowledge, but clinical reasoning, communication skills, and confidence. And all can be developed through structured and experiential learning. So that's the current state of where medical education currently is in regards to prescribing education. Moving on, let's look at the need for improved prescribing education. Starting with the WHO, the World Health Organization has emphasized the need for medication safety at a global level. So aligning prescribing education with the World Health Organization's goals can help reduce preventable harm across healthcare systems. Reforming curricula is not just beneficial, but is something imperative. We must move from passive knowledge transfer, which is happening very frequently in many schools, to active skills-based education, competency-based education that prepares students for the complexity and the responsibility of prescribing. So the two pillars must support modern prescribing education. One is having hands-on. As I was mentioning earlier on, there's a lack of hands-on practice apart from a lack of standardized curriculum. And there's another also important pillar that we need to emphasize currently is because the emergence of e-prescribing system. So it's important that our medical school starts to train the medical students on how to prescribe using electronic systems. Students should routinely engage in writing, physical writing prescriptions, calculating doses, reviewing medications, and taking medication histories properly. And at the same time, also able to prescribe using electronic systems. These are foundational tasks that cannot be learned theoretically. So hands-on is very important. Some of the studies have shown that certain schools have used pharmacist-led teaching and part of interprofessional education can enhance the students' ability to make clinical judgment and also enhance safety of prescribing. Moving on, 2023, quite recent, scoping review identified a range of effective educational interventions, and this include e-learning. They also found that experiential learning is very important, and also the utilization of interprofessional modules. All of these interventions have improved learning outcomes. However, the significant results were only shown at Kirkpatrick's level 1 and 2. So further studies needs to be done to assess Kirkpatrick level 3 and 4, whether if there is actually a significant impact from the educational intervention. But basically, they have done level 1 and 2 and assessing how these interventions can actually change perception and behavior. So we need further studies to ascertain there's an actual clinical impact from these educational interventions. So as I mentioned, apart from being able to train students to use an electronic prescribing system, also use electronic or e-learning platform to prescribing. E-learning platforms like the British Pharmacological Society assessment platform allow students to make decisions in a risk-free environment. They can explore the consequences of errors without harming actual patients. And people should incorporate these tools not only as add-ons, but as core elements of their medical education. So this can enhance engagement, skill retention, and also fosters reflective practice. Interprofessional education and collaboration, again, is something very important. As I was just mentioning a while ago, that prescribing is rarely a solo act. It's part of a care continuum. So interprofessional education brings doctors, pharmacists, nurses together in learning environments, enhancing mutual understanding, and also obviously can reduce errors. So meanwhile, e-prescribing training is also critical. So as I was mentioning, in the curriculum, there should be some component that teaches the students, apart from being able to write a prescription physically, to be able to prescribe on e-prescribing systems. There are obviously benefits of these systems. They improve clarity and safety, but only when the users are trained properly in using them. Otherwise, their errors can still happen. So we must teach both traditional as well as digital prescribing skills in the curricula. So moving on to the last section, let's look at some examples of interventions that have shown positive impact or effectiveness in improving prescribing safety. Allow me to start by introducing this trial called the Prescribe trial, which was done looking at simulation-based training. And it was found that it can reduce prescribing errors significantly for pharmacology and prescribing. So realistically, immersive scenario can push students to apply knowledge, make decisions, and learn from mistakes. Institutions adopting such type of frameworks reported up to about 30% reduction in errors within a year. So this evidence showed a broader integration. It's definitely encouraged using simulation to teaching practice. Another interesting point to mention is this UPAC framework and its adoption. This is mainly adopted in Europe. It is a framework that was established to enhance prescribing safety in medical education across Europe back in 2021, so during the COVID time. At first, 10 institutions adopted the framework, which is marking the beginning of its integration into the curricula. And a year later, in 2022, the number has grown to 20 institutions, reported improvements in prescribing preparedness following the framework's implementation. And then the following year, 30 institutions across Europe fully integrated the UPAC framework. into their programs, and they reported about 30% reduction in prescribing errors was observed. So having said that, I have prepared 3 case studies to share with everyone that has implemented an educational intervention and have shown promising results in terms of better outcomes and better prescribing competency. The first one was a randomized control trial for a 1-week drug-related problem module, which was delivered to 74 Year 5 medical students. And it was found that the prescribing error rates before the training was 69%. And after the training of this 1 week's drug-related problems training, it has reduced to 29%. So this is very statistically significant. And the training basically included seminars, practical exercises, patient charts were shared to the students, and there's reflective discussion within this module. So this has illustrated that even short but very well-designed interventions can yield dramatic improvements. The second case, it's a study that has compared traditional pharmacology teaching with a small group teaching format called problem-based learning, PBL. So PBL, in this study, PBL students have higher knowledge scores, made fewer inappropriate therapy choices, and felt more confident in prescribing. They also had more practical exposure to prescribing tasks, and these results reinforce the value of active scenario-based methods to teach prescribing. The final case that I like to share, it's a pilot study comparing e-prescribing with traditional methods using pen and paper type of prescribing among 300-odd students. It was found that the errors dropped from over 40% to under 5% with e-prescribing. So it shows that using an electronic system to prescribe can reduce error, but there are certain areas where errors are still prone or even higher, for example, like in the dosage. So that actually tells us that technology must be accompanied by training nonetheless in pharmacological reasoning. So competency development must address both strengths and risks of digital tools. Other emerging approaches in terms of educational interventions are like game-based learning, using the prescribing safety assessment or prescribing skills assessment by the BPS assessment. Also, it's a form of a way forward, and also maintaining ongoing education for prescribing practices are other approaches that we can use. So moving on from learning, let's look at assessment. So just a very short one, assessment drives learning. We all know that, and we must assess prescribing competence using different methods like OSCEs, simulations. We can have written tests and feedback from real clinical settings. Apart from that, evaluation of our programs are also important. In evaluation of the students' progress doesn't end at the at graduation. So some sort of longitudinal studies is needed to track how prescribing education impacts behavior, confidence, and patient safety over time. So as we look ahead, the WHO's Good Prescribing Guide offers a strong foundation. So it's a good place to start for medical schools are just starting off. Future priorities include longitudinal studies at Kirkpatrick level 3 and 4, as I mentioned, as level 1 and 2 has been shown, but 3 and 4, there's a lack of studies that has shown level 3 and 4. So research into behavioral change and more real-world assessment of competence is still needed. We also need innovation as I mentioned, some game-based or augmented reality even, or AI-driven feedback can, we believe, enrich future prescribing education. Last but not least, there are policies that needs to be put in place from a perspective of policymakers. Standardization is critical. So perhaps, if possible, national framework should define core prescribing competencies that is supported by assessment and practical training. So again, to wrap up, the recommendations are we need to educate students early on about common errors that can happen in prescribing and their consequences, i.e. Causing harm to patients. We need to provide regular assessments, both written and practical, implement robust e-prescribing training with real-life simulations, and most importantly, demonstrate that new doctors that are graduating from medical schools can prescribe safely before they take on their clinical work. These are not too ambitious. They are achievable and they are a necessity if patient safety is our priority. To go with that, also research must go deeper, educational research. We need robust longitudinal studies that evaluate not only knowledge, but actual prescribing behavior and patient outcomes. So to summarize, prescribing errors are prevalent, they are preventable, and can be dangerous. So this is, let's work together to bridge the gap between education and clinical reality. And my call to action is let's commit for everyone, educators, clinicians, policymakers, let's commit to embedding safe prescribing into the core of medical education. Let's ensure every graduate can prescribe safely worldwide, confidently and competently. Because behind every prescription is a patient, and behind every error, there is a preventable risk. Thank you very much for your time and dedication to this cause.